The cavernous sinus is part of the dural sinus system, but also forms a complex anastomosis with veins of the face. Within this venous network, blood flows bidirectionally into and out of the cranial cavity. Consequently, infection can follow these routes to the cavernous sinus, leading to a life-threatening condition called cavernous sinus thrombosis. Within the danger triangle of the face, infection can access the facial vein or angular vein. From here, blood can carry the infection to the superior ophthalmic vein or inferior ophthalmic vein, through the superior orbital fissure, and into the cavernous sinus. Alternatively, the infraorbital vein and deep facial vein provide routes for infection by linking with the pterygoid plexus of veins. This plexus branches through the inferior orbital fissure to merge with the inferior ophthalmic vein. Additionally, emissary veins allow venous blood to pass in and out of the cranial cavity. These veins are small and pass through various foramina in the skull base to communicate with the cavernous sinus. Similar anastomoses are relevant to routine dental procedures too. Following a tooth extraction, for example, small blood vessels in the maxilla or mandible may be left vulnerable to infection or emboli. From these regions, blood passes through the superior alveolar veins or inferior alveolar veins before reaching the pterygoid plexus. When a thrombus affects the cavernous sinus, several cranial nerves supplying the extraocular muscles are at risk. Cranial nerve 6 is most vulnerable as it runs directly through the sinus. Cranial nerves 3, 4, V1, and V2 run along the lateral walls of the sinus. The optic chiasm, or cranial nerve 2, is situated above the cavernous sinus. A thrombus impinging these nerves typically results in loss of eye movement, reduced vision, and sensory deprivation of the midface. Another common symptom includes periorbital edema due to the blockage of blood flow caused by the thrombus. A short section of the internal carotid artery is located within the cavernous sinus as well. A thrombus could put pressure on the artery, limiting blood flow to the cerebral hemispheres. Each side of the cavernous sinus is connected by an anterior and posterior intercavernous sinus. A thrombus may potentially grow through these channels, impinging the pituitary gland in the process. Exiting the cavernous sinus are the petrosal sinuses. The superior petrosal sinus moves venous blood to the sigmoid sinus, which flows into the internal jugular vein. The inferior petrosal sinus drains directly into the internal jugular vein. If the thrombus breaks apart, resulting emboli could follow these routes towards the heart and lungs, leading to a potentially fatal pulmonary embolism. Fortunately, occurrences of cavernous sinus thrombosis are rare. Cases vary greatly depending on the individual anatomy of the patient or whether the cause for infection is septic or aseptic. To avoid long-term cranial nerve damage and restore proper blood flow throughout the cranium, quick diagnosis and treatment is crucial. CST was almost uniformly fatal prior to the invention of antibiotic therapy. Using anticoagulants early in the treatment of CST has also shown to prevent further thrombosis and reduce incidences of septic emboli. Remembering the cavernous sinus's relationship with the venous network of the face is important so as to consider CST in the differential diagnosis.